Afternoon. Now we move on to the next session of this afternoon. And for this, I'd like to invite our chairperson, Dr. Javinder Yadav, who is an associate professor, pediatric endocrinology unit at PGIMR, Chandigarh. And Dr. Javinder's special area of interest are growth, puberty, and adrenal disorders, along with DSD. Over to you, sir.
So thank you, ma'am, for the kind introduction. So we will be beginning with this interesting session, and the speaker for this session is Professor Arvind Banga, and all of you must be knowing sir. Sir is former professor and head pediatric nephrology unit at AIIMS New Delhi, and currently sir is senior consultant at Apollo Hospitals Delhi. So I welcome sir, and please deliver your talks. Thank you.
Thank you, Javindra. And thank you for the invite. And what we intend doing over the next 40-45 minutes is I'll discuss chiefly about the pathophysiology and the diagnosis, some diagnostic evaluation of renal tubular acidosis. And Dr. Srinivas, my colleague, will be speaking about the management, the principles of management in brief. And I'm sure many of you are aware about this literary character, Tiny Tim, one of the early, in fact, the first Charles Dickens novel, Christmas Carol, and it's assumed or presumed that this character, Tiny Tim, really had distal RTA, although it's not really proven. There are not too many other literary characters, that have been kind of associated. So while beginning, this audience is aware, the role of the kidney in acid-base homeostasis is chiefly in bicarbonate reabsorption, which would be happening across the entire tubule, but chiefly in the proximal segments. In addition, there is a very major element of proton secretion, which is less recognized. But proton secretion is almost necessary because daily when we are consuming a diet, and chiefly with the animal-based diet, one is kind of producing almost a milliequivalent per kg per day of protons, and these have to be neutralized. In addition, in children, when bone hydroxyapatite is being laid down, again you are consuming bicarbonate. So clearly one does need to regenerate bicarbonate, and by the process of proton secretion that happens in the distal tubule chiefly, one is able to regenerate bicarbonate to the tune that you are able to achieve. Thank you. So you are able to achieve this acid production that's happening to be able to buffer this. And the protons are secreted chiefly in three ways. We know that they're secreted as free hydrogen ions, as you can see here. But protons are also secreted as titrable acids like H2PO4, and but chiefly as ammonium. And ammonium is a very important way by which the body gets rid of excess hydrogen ions during states of acidosis. Very briefly, over the next 2 or 3 slides, I'll talk to you about the chief transporters in the kidney that are responsible for doing this. We know that in the proximal tubule, you have got the sodium bicarbonate co-transporter here on the basolateral side, and you have got the sodium hydrogen ion exchanger, which is on the luminal side, and they are responsible for transporting sodium across the tubule. In addition, there is hydrogen ion secretion that's happening here. This hydrogen ions would combine with bicarbonate that are coming from the glomerular filtrate to form H2CO3, which is then broken down to CO2 and water. Now, in the proximal tubule, the CO2 gets reabsorbed into the proximal tubule. But when you go more distally, the CO2 in the urine is not getting reabsorbed, chiefly because the epithelium becomes columnar, instead of cuboidal. And therefore, this absorption doesn't happen. So, urine CO2 that you are finally estimating, and we'll talk about this later, is really a marker of distal hydrogen ion secretion. In addition, over the past few years, there has been a lot more knowledge regarding the other important genes and proteins that they make. So clearly, I'm sure you have heard about Dent's disease, where you have a problem in the CLCN5, cystinosin, and so on. So clearly, there are many more proteins and genes that we know of now that are involved in proximal tubular function. And when you have a problem in any of these genes or proteins, you end up getting what we now call the Fanconi syndrome or the Fanconi renal tubular syndrome. In the distal tubule compared to the proximal tubule, you really have two major cells, the principal cells and the alpha intercalated cells. And the principal cells are chiefly involved in sodium absorption and potassium hydrogen and potassium secretion through the well-known Ronke channels. In addition, there are also echoporin channels in the principal cells, but the alpha intercalated cells are the chief cells that secrete hydrogen ions, and there is the hydrogen ATPase, and the common genes are shown here, which is the chief way by which hydrogen ions are being secreted by the distal tubule. And there is the anion exchanger on the basolateral side, which absorbs bicarbonate and secretes chloride. And again, problems in all these genes are now well known to cause distal RT, and as we'll discuss later. The third slide on pathophysiology is really the slide pertaining to ammonia genesis. As I said, that ammonium ion is the chief ion by which hydrogen ions are buffered in the tubular lumen during states of acidosis. And the ammonia genesis is chiefly happening in the proximal tubule by deamidation of glutamine, and each molecule of glutamine would lead to release of ammonium as well as ammonia, as also bicarbonate ions. In addition, so now once you get ammonia that's being passed out in the tubular lumen, the ammonia does go through the entire nephron. It's reabsorbed by the sodium potassium cotransporter in the loop of Henle. In the loop of Henle, and thereafter it goes into the interstitium, and then it is secreted in the distal tubule, and the ammonia that you get here would combine with the hydrogen ions that are being secreted by the alpha intercalated cells and come out in the urine as ammonium. So ammonia handling is a bit more kind of complex than the other ions that we just spoken about. Now, as clinicians, when do we suspect renal tubular acidosis? And I will not go over this list, but I'm sure you are well aware, but essentially short stature, refractory rickets, calculi, nephrocalcinosis, and so on, polyuria, polydipsia, these features are well known to you. In addition to the clinical features that are just listed here, there are some metabolic aberrations, chiefly a normal anion gap metabolic acidosis, the presence of hypokalemia with acidosis, and so on, So there are some markers that would make you suspect or think about renal tubular acidosis. Now, the first step when you're evaluating a patient with metabolic acidosis is to look at the anion gap. And again, you are well aware what the anion gap means. It's really the difference between the sum of unmeasured anions and the unmeasured cations. And the chief unmeasured anions are shown here, and the cations are listed here. But if you use this formula, the normal anion gap is about 8 to 12 milliequivalents per liter. And patients who have got diarrhea, patients who have got renal tubular acidosis, and some other rarer disorders would have a normal anion gap metabolic acidosis. So the bicarb would go down, but the chloride would come up. And therefore, the chloride to bicarb ratio is something like 0.8. In addition, and compared to the normal anion gap metabolic acidosis, you have got situations wherein the anion gap may be increased, and there are various acronyms and things that you can memorize, which are well known. Now, when evaluating a patient with hypochloremic metabolic acidosis or normal anion gap metabolic acidosis, we would normally teach our residents, that we would be following certain steps. Look at the urine pH, look at the urine anion gap, try to define this as proximal or distal renal tubular acidosis, and once you have defined that, try to determine the underlying etiology, and obviously I'll talk in some detail regarding the role of genetics. Now, the first step in evaluating a patient with normal anion gap metabolic acidosis would be to look at the urine pH. And that's a test that you normally would do. But remember that when you're looking at the urine pH, don't use a strip. It should be done with a pH meter. The strip is just too insensitive to be able to pick it up, The only thing is that please remember that urine pH is just measuring the free hydrogen ions. And as I told you in the first slide, that the kidney is handling or secreting hydrogen ions as titrable acids and ammonium. So this is only looking at one component of the hydrogen ion secretion. And there are some caveats that you should remember. Imagine a child with severe diarrhea, hypovolemia, and thereby having a low urinary sodium. When you have a low urinary sodium, you would have less hydrogen ions being secreted, because in exchange, you would be trying to conserve sodium, and thereby you would not secrete enough. So, in acute diarrhea, particularly with hypovolemia, the urine pH may be inappropriately high. Don't label this as RTE or whatever you know. And the same is true with chronic acidosis. When you have chronic acidosis, the body makes more ammonia, because it's a way to get rid of the additional hydrogen ions. And this ammonia is going to mop up all the hydrogen ions that are there in the urine, and thereby you would end up getting more ammonium and less of free hydrogen ions. And this free hydrogen ions you are picking up anyway by the pH paper or with a pH meter. So clearly, both in states of acute diarrhea or hypovolemic states, or in patients who've got chronic metabolic acidosis, the urine pH is fallaciously overdiagnosing renal tubular acidosis. So pH is good is a good screening tool, but keep in mind the problems that are associated. So what we often do is that we would be doing an ammonium chloride loading test. When I was a resident, this would be a commonly used test in which you give ammonium chloride a standard dose, and then you check the urine pH over the next 6 hours. And the technique is shown here, and there are some situations wherein you will not do a ammonium chloride test and so on. But remember that ammonium chloride is tough to take. A number of kids would just throw out, and they would not accept ammonium chloride. But if you are able to do a successful ammonium chloride loading test, and the blood pH does decline and the plasma CO2 does fall, and if you are able to achieve a urine pH of below 5.3, it excludes a distilled acidification defect. So doing an ammonium chloride loading test does help you distinguish distal from proximal RTA, in the sense that a proximal RTA would be able to acidify well, but a distal RTA would not be able to acidify. As an alternative, because doing an ammonium chloride loading test is tough, what we often currently do, at least in our wards, is that we rely on the furosemide fludrocortisone test. And again, the basis is similar. You're giving furosemide and fludrocortisone. What furosemide is doing is that it's kind of leading to increased distal sodium delivery, and fludrocortisone is leading to absorption of this sodium that's being delivered. And both would enhance hydrogen ion secretion. So when you give both these things together, the urine pH should normally fall down to below 5.3. If it does not fall, then there's a very high index that there is clearly a distal acidification defect. And clearly, most nephrology units, and I'm sure a lot of endocrinology units, would also be using the furosemide fludrocortisone test as the initial screening test to look for distal tubular acidification. The guidelines do say, that while this is a screening test, and if you get a positive furosemide fludrocortisone test, always confirmed by ammonium chloride. But generally speaking, we would generally, if you get a pH that does not fall, we assume that this is abnormal. And very often, I think the role of ammonium chloride loading test has gradually declined. The other important aspect, that's been discussed a lot over the last, I can say at least 3 or 3.5 decades, has been the urine anion gap. As is shown here, the urine anion gap is really an estimate of the urinary ammonium excretion. Therefore, if you have got a normal kidney, and if you are in a state of metabolic acidosis, and the urine ammonium secretion is normal, the anion gap should ideally be negative. Okay, and if the anion gap is not negative in a state of acidosis, then you would suspect that the ammonium excretion is not appropriate, and perhaps this is a state of which would strongly suggest renal tubular acidosis. And this test has been used for a number of years now, but recently, people are doubting the utility of the urine anion gap, and to the extent, that some experts would say that the urine anion gap does not really add too much to the over the urine pH, although they are testing two different things. They're not testing the same thing. It also depends a lot on the diet that you are taking. So whether it's a plant-based diet versus animal diet, the anion gap may vary. And there is a move, at least within nephrology, to replace anion gap with direct estimation of urinary ammonium, and say that you should estimate ammonium directly rather than relying on a surrogate test. Practically speaking, as far as what I have seen in the last 3 decades of my practice, the role of an anion gap has declined. There was a time when it really was at its peak, but clearly anion gap is less often used in evaluating children with suspected renal tubular acidosis. The third test, which is kind of talked a lot about, but it's very cumbersome to do, is the bicarb loading test. And I'm sure that you've read about this, but most labs across the country and even across the world do have problems doing this test, chiefly because you need to have a sample of urine that is preferably collected under oil, and then it is put into the blood gas machine. And most technicians, they're not happy handling urine samples in a blood gas instrument. They say they tends to get faulty very soon and so on. So while it's a good test to understand the basis of RTA, uh, we are still doing it at AIMS, but I'm not sure that it's a test that's universally used. And when you talk to experts across the world, they would often rely on genetics rather than going through this route anymore. So clearly this test is kind of, because it's tough to do, but the aim is to give enough bicarb to the body, either by orally or intravenously, so as to raise the bicarb to about 18 or 20. And at that point in time, you estimate two things. You're looking at the fractional excretion of bicarbonate, which is normally below 5%. And in proximal RTA, the Fe bicarb would be more than 15% or more than 12%. In distal RTA, again, it's more normal than proximal RTA. The second thing, what the bicarb loading test does is that it also simultaneously assesses for distal hydrogen ion secretion. Therefore, when you're in a bicarb loaded state, remember the first picture that we discussed, you're getting so much bicarb through the glomerular filter. And if you've got an active hydrogen ATPase system in the distal tubule, you will end up forming H2CO3 in the tubular lumen. The H2CO3 will degrade to water and CO2, and because the CO2 cannot go back in the distal tubule, because the distal tubule is rather impermeable to CO2, you will get a high urine CO2 in a normal situation, as compared to a distal RTA where there is no hydrogen ion secretion, and therefore you would not get enough CO2 in the urine. So you can use this single test to diagnose both proximal as well as distal RTA. But as I said, there are problems in doing the test, doing it promptly and so on. And therefore, there is less reliance at times, and one would often bypasses this test. Moving on to proximal RTA, most proximal RTA that we would encounter as pediatricians would be in a setting of Fanconi syndrome. And that the Fanconi syndrome, or what was now called the Fanconi renal tubular syndrome, is really a combination of a number of losses of a number of ions or substances in the urine. But the most constant, and what you're looking at most importantly, is the presence of tubular proteinuria and amino acid urea. You may or may not have phosphaturia, you may or may not have glucoseuria, but you always have to have loss of low molecular weight proteins in the urine and or amino acid urea. And the low molecular weight proteins that you're looking at is either retinol binding protein or beta-2 microglobulin and so on. And then you would obviously have features of individual diseases. If you've got low phosphates, one would evaluate them by standard tests, including looking at the tubular reabsorption of phosphate, looking at the TMP GFR, which is a better marker of phosphate handling than Fe phosphate alone, either directly or using a BO-Waze nomogram. Finally, once you are able to define patients as having proximal or distal RTA, you then figure out, is there an underlying secondary etiology? And there are, various clinical markers that one can use, and I will just rapidly go through this. So the first is the slit lamp showing cystine crystals in the eye. The second is a child with what? Somebody did say something. Loeys syndrome, yeah. The third is a child with cataract. Now this could happen, say, with galactosemia, but could often happen with the NBC co-transporter in the proximal tubule, the sodium bicarbonate co-transporter. And this is a child diagnosis. What is this? Child with renal tubular acidosis, some developmental delay, and you can see calcifications in the brain. Osteopetrosis, very good. So dense bones, and in fact, osteopetrosis is the only condition that has both proximal and distal RTA. There are very few conditions that has the combination. The only drugs that can mimic osteopetrosis is acetazolamide and this other drug. What's the name? Topiramate, Topiramate, that also blocks the carbonic anhydrase enzyme. So these two enzymes, these two drugs can mimic this. But otherwise, you don't have this combination of proximal and distal. We'll talk about why some patients with distal at times show proximal acidosis. And then you have got the classic elliptocytosis, which could happen with the anion exchanger problem, Always remember as pediatricians that while you have primary RTA, and that's a very important part, there is a host of conditions that can cause secondary RTA. And you don't need to go into details, but clearly, there is a multitude of conditions that can cause multiple systemic diseases that can cause acquired forms of RTA, both distal, proximal, as well as type 4. Also remember, that when you have got conditions like, and this is more for nephrologists, if you have got conditions like obstructive uropathy, FSGS, etc., don't label them as having RTA, because here you've got a primary organic defect or a primary structural defect in the kidney that's causing everything. Next few slides, I'll talk very briefly about the genetics. Clearly, because, this thing has changed the way we have understand RTA in the last 10 years. The chief genes for distal RTA, as I said, is the hydrogen ATPase that's shown here, which on the luminal side. And on the other side, you have got the anion exchanger or SLC4A1. In addition, you have got the FOXY1, which is really a master regulator gene that regulates the expression of both the hydrogen ATPase as well as the anion exchanger. And there is also another gene which we'll talk about, WDR72. And each of these genetic disorders, they would have a reasonably clear phenotype. I'm not saying, that you don't need to do genetics, but many of them would have a reasonable clear phenotype. For example, deafness is a feature mainly of the hydrogen ATPase or of FOXY1. FOXY1 is a recently described condition. On the other hand, when you have got anion exchanger defects, many patients who've got anion exchanger defects, they may have anemia, which is hereditary spherocytosis or elliptocytosis and so on. So there is a reasonable degree of, genotype, phenotype correlation that is there. And each region would have its own hotspots of various genes. If you look at the worldwide data, the hydrogen ATPase is clearly the predominant gene in the Caucasian population in Europe, and I don't know, I don't have data from North America, but clearly I'm sure the data would be similar. And the anion exchanger is clearly lower. You don't need to look at the entire slide, and the genotype phenotype correlations are still there. Patients who've got the hydrogen ATPase would generally begin early than the SLC4A1 or the anion exchanger. So clearly the hydrogen ATPase defects are more commoner. Also remember that almost 75% patients with distal RTA would show a genetic defect. So there is about 25% often distal RTA still. This figure is repeated multiple times, whatever series you look at. Like there's another European cohort. And during the last 3 years, there is a lot of data emerging from India. This is data from JIPMER. Again showing, that refractory rickets, of all the patients with refractory rickets, they had variants of the RTA. They showed variants in 77% patients. But interestingly, in JIPMER, they found that the anion exchanger was much more commoner than the hydrogen ATPase. This is again recapitulated if you look at the ICMR data, which is the registry is still going on, being managed at AIIMS Bhopal by Dr. Girish Bhatt and his team. Again, showing that SLC4A1 is the chief gene in the Indian population, but you have about 25% often where you still don't find an underlying cause. I will not go into too much details, and there is similar data from the institute, where again, in fact, Sukanya is sitting here. Yeah, Sukanya's thesis during her MD, she kind of looked at this, and again, she again showed, that SLC4A1 was perhaps the commonest defect, and then you have got other hydrogen ATPases as well, and good clinical genotype phenotype correlation. The other disease, that's being seen, interestingly, has been reported more from Asia than from Europe, has been the association with WDR72. So about 5 years back, we started seeing children who had amelogenesis imperfecta. So they had lack of development of their enamel along with features of RTA. And the acidosis was not very severe, but they had refractory rickets. They had a mild rate-dependent RTA. They had polyuria and so on. A proportion of them also had proximal dysfunction, and we'll talk about proximal dysfunction later. And we found, that this was linked to WDR72, and there are reports that WDR72 is an important gene. And recently, from Pondicherry, Dr. Deepthi published a series of 22 patients from across the entire country, again showing that whenever you have patients with RTA, look at the teeth as well. So patients with distal RTA may have features that are kind of specific to the gene, and we have discussed this already. In addition, there are metabolic defects, so chiefly hyperchloremic acidosis, hyperchloremic acidosis, hypokalemia. In addition, many of these patients would show low molecular weight proteinuria, and we'll talk about this in a minute. Rickets, osteomalacia, and uh, patients with RTA would also have hypercalciuria and hypocitraturia. Now, it's important to understand that the hypercalciuria and the hypocitraturia is acidosis dependent. Once you treat the acidosis, these things go away. So I think one of the targets when we are using bicarb supplements or citrate supplements is to be able to reduce the hypercalciuria and hypocitraturia. All these are risk factors for stones, because if you have got hypercalciuria, hypocitraturia, high urine pH, these are the classic ingredients wherein you can get problems. And this is interestingly a good article, which maybe at least the fellows should read, Nature Review Nephrology. It's a good review article on distal RTA. Another problem, that clinicians encounter is that you have a classic distal RTA. And this distal RTA is also showing some features of proximal dysfunction. So you have a classic distal RTA, but there is low molecular weight proteinuria. There is phosphaturia. So is this a mixed RTA? As I said, mixed RTA, apart from carbonic anhydrase deficiency, does not happen. But what's been seen over the last few, it may be at least now 4.5 decades, is that patients who have got a distal RTA, because of the acidic milieu, they may show some proximal dysfunction. And as the acidic milieu gets better with treatment, the distal RTA, the proximal dysfunction also improves. Interestingly, the initial papers have said that while they may have other proximal dysfunction, glucosuria is not a feature. But that's not invariable. I recently saw a patient who also had glucosuria. So you can get proximal dysfunction with distal RTA, which is correctable once you treat the acidosis. Don't waste too much time on this slide, but it's not to create confusion. But whenever you have hypercalciuria with low molecular weight proteinuria and mild acidosis, do think about DENT. This is a condition, that we have recognized in the last 2 decades. So clearly, it can often mimic early renal tubular acidosis, and they often would have hypercalciuria and low molecular weight proteinuria. And you have a DENT1, DENT2, multiple genes. We won't go into those details now. What about incomplete RTA? Now, is this a disorder that's worth mentioning? If you read the older literature, clearly it's a disease in which which you would suspect, based on what is listed here, adults with osteoporosis, obstructive uropathy, patients who've got stones, and you've got a high urine pH. So they do not manifest metabolic acidosis, but they would have difficulty in acidifying urine when you load them with either ammonium chloride or if you do a fludrocortisone test. And incomplete RTA is perhaps one step before RTA, and there is enough discussion happening, at least in pediatric nephrology fora, that is incomplete distal RTA really real, and could these be the heterozygotes of distal RTA that do not show the full form of the disease? But once you diagnose incomplete distal RTA, then one would treat them similarly. Just one slide, on the various causes of Fanconi syndrome. When we talked about Fanconi syndrome before, the only disease that used to come to our mind was cystinosis, galactosemia, and other diseases were less commonly diagnosed. But over the years, with better application of genetics, clearly the list has expanded, and you have various forms of Fanconi syndrome, or what is now increasingly being called Fanconi renal tubular syndrome. I have checked this, whether there's a real difference. There's no real difference if you read the literature. Although when the renal tubular syndrome was first described, it was really limited to only the kidney being involved. But I think there are a number of renal tubular syndromes that also have systemic features. And these are listed here. The ones that are underlined are perhaps more commoner than the ones that are not underlined. And the renal tubular syndromes are shown in red. But you can see the number of genes, that have now become apparent. And clearly there are papers on each of these genes. So again, saying, that when you are faced with a patient one cannot but not do genetics to be able to figure out what's the likely cause. We'll leave this. Uh, Hyperkalemic RTA is uncommon in children. When do you suspect hyperkalemic RTA? Suspect hyperkalemic RTA if you've got a patient who's got acidosis with hyperkalemia, with normal ability to acidify the urine. Okay, and so this would be the clinical phenotype. The next test to do would be to do a plasma aldosterone and a renin, and then try to classify in which category a patient falls. I'm sure as endocrinologists you are seeing much more of type 4 RTA, particularly PHA type 1 and PHA type 3, which is a transient phenomenon. Gordon's is rare. We at least have not seen more than a couple of patients, but you can categorize based on this algorithm that's shown here. So this is really the last slide before we have the discussion on therapy. So if you have a patient with hyperchloremic metabolic acidosis, it's a normal anion gap acidosis, one would look at the urine anion gap. I've already told you the problems, with the anion gap, and less people now following this step. And then the next set of investigations are looking at the urine pH, looking at the serum bicarb, and if possible, do a bicarb loading. Patients with proximal RTA would be able to acidify the urine well. They would have a high level of fractional excretion of bicarbonate, because that's what defines proximal RTA. And then you would have to evaluate for other proximal defects. Patients with distal RTA would not be able to acidify the urine well. The potassium levels will be low. They have a normal Fe bicarb, so the bicarb handling is okay, but the U minus B CO2 difference, because they are not able to acidify the urine well, would be negative or definitely below 10 millimeters of mercury. And patient with distal RTA would have a appropriate urine pH, so they are able to acidify well, but they would have hyperkalemia and acidosis. And based on this, then you would be able to. So mostly, one is able to define and categorize patients reasonably well. And obviously, genetics would become an important tool in being able to ascertain the underlying cause. I'll stop here, and maybe Srinivas, if you can continue.
Thank you, sir. In the next subsequent 10-15 minutes, we will be going through the management aspects of renal tubular acidosis. We will be covering the correction of metabolic abnormalities, delaying the disease progression, as we know that they are prone to develop chronic kidney disease, nutrition and growth aspect, which is part of a pediatric management, and management of comorbidities like rickets. So first metabolic abnormality we would dealt with is the metabolic acidosis. Once a child presents with an acute decompensation, the deficit has to be calculated using this equation, and it has to be infused over 2 to 4 hours as diluted with 5% dextrose. Once this deficit is being corrected, then there should be supplements of alkali, which is broadly categorized into two as either citrate based or bicarbonate based, and the salt either by sodium based or the potassium based. So citrate based is helpful as they are long acting in terms of they have to be converted to bicarbonate from the liver, and they also have glucuronidization that increases their THOF. Similarly, the bicarbonate based formulations have concerns in terms of CO2 generation in the gastric lumina, and they can cause belching. Coming to the electrolyte, that is the potassium and the sodium, potassium citrate would be beneficial in terms of renal tubular acidosis, as we would have both hypokalemia in association with metabolic acidosis. And the disadvantage of sodium containing salts include that they are prone to increase the body fluids. That results in decreased reabsorption of bicarbonate in the distal tubule, as well as they also increase the excretion of calcium that results in hypercalciuria and increase the progression of nephrocalcinosis. We could note that overall, although the alkali requirement is there for both the proximal as well as the distal RTA, the proximal, as they lose more bicarbonate rather than in distal where bicarbonate is need to be neutralizing the acidotic state, they require higher bicarbonate supplementation in comparison to the distal component. And similarly, the alkali doses requirement is higher in the younger age group, as they have an increased bone turnover and high acid load for the body surface area, which needs a higher alkali for neutralizing these agents. So the dose required would be, for newborns it's around 5 to 8 milliequivalents per kg per day, and for children it is 3 to 4, and when it comes to adolescent and adults it would be 1 to 2 milliequivalents per kg per day. So the it has to be given frequently as of almost 6 hourly. So that always has a issue with the compliance. So that there is a prolonged release formulation which is available in market, which is component of both potassium citrate and potassium bicarbonate, which each sachet contains 8 and 24 milliequivalents. Both are available, and these can be used as a twice daily basis so that the compliance can be ensured. These are the two studies from the Europe, especially from France, where they had shown that they have been associated with better potassium and bicarbonate control, and they have been also been shown to have a good gastrointestinal safety. They have also been shown to have a good anthropometric response. This is a 2-year follow-up study where we could see that both the height and weight have been improved. So moving on to the next electrolyte abnormality, which is hypokalemia. So as we all know, hypokalemia, when they present as an acute emergency, especially in a renal tubular acidosis, they can present as acute flaccid paralysis. Also, they can also have manifestations of cardiac in terms of arrhythmia. So when patient present with severe hypokalemia or symptomatic hypokalemia, the management would be with IV infusion of potassium chloride that can be given as a dose of 1 milliequivalent per kg. However, the most important factor is the correction rate. That is the maximum we can give up to 0.5 milliequivalent per kg per hour. And especially as potassium chloride is hyperosmolar, so it will cause thrombophlebitis. So the dilution is at most important. If you are using a peripheral cannula, it should be diluted to the maximum of 40 milliequivalents per liter. And if it is a central catheter, then it could be up to the maximum of 200 milliequivalents per liter. As renal tubular acidosis is a polyuric state, there is no concern about the volume to be used. Subsequently, for the chronic management, there are formulations available, as I already mentioned, potassium citrate. In terms of these are the examples which are available in our market, and potassium chloride can be used when there is acidosis being corrected but still hypokalemia is persisting. Similar to the previous one, there is one prolonged release formulation also available. They have to be dosed at 3 to 4 times a day, as they have a very short half-life, and they have to be diluted in water as they are associated with severe gastritis. This it will be till now it will be common for both the proximal as well as the distal renal tubular acidosis. The next component would be hypophosphatemia, which is particular for the proximal renal tubular acidosis. Acute management in terms of patients might not present with severe symptoms of hypophosphatemia, but the value of less than 1.5, it is been reported to develop rhabdomyolysis. So it is an acute emergency to correct the hypophosphatemia. So correction would be with IV infusion of potassium phosphate. It comes as a vial of 1 ml, contains 93 milligram, and the dose would be 5 to 10 milligram per kg over next 6 hours. And then the chronic management for these patients, although this slide mentions 20 to 60 milligram per kg per day, the maximum that we can go is 75 milligram per kg per day. And remember, they have to be given at a very significant divided doses, that is around almost 6 divided doses, because of their very short half-life. The most commonly used is the sodium phosphate agents, which includes one is the Adphos, which is commonly available now, which has one sachet contains 500 milligram of inorganic phosphorus, and the other commonly used are the neutral phosphate and the Julie solution. Neutral phosphate tablet contains one tablet of 250 milligram, and the Julie solution has 1 ml 30 milligram. So can diet support this maintenance of these electrolyte abnormalities? Yes, there is maintenance of lesser acid based diets. We can calculate using the PRAL score, which is the potential renal acid load score. Dietitians can help us in calculating this and decrease the acid based diet so that the load in children can be decreased. Similarly, potassium rich foods and phosphate rich foods can also be advised for children in terms of diet management. Why is metabolic correction important? This is a follow-up study of almost 340 children and adults with distal RTA. Here we could see that patients who had adequate metabolic control had a better height SDS score, as well as the preservation of kidney function in terms of metabolic control. Similarly, there has been a correlation between the bicarbonate levels and the bone mineral density in all these patients. So, as I already mentioned, they are also known to be progressing to chronic kidney disease. This is the same registry where we could see that almost 32% patients have had a progression to chronic kidney disease stage 2, and this graph shows a negative correlation that increasing age decreases the GFR. And this is the longest follow-up data from distal RTA, where almost 71% of children had progressed to chronic kidney disease. So, what are the factors that contribute for development of progression to chronic kidney disease, which includes the persistent metabolic acidosis and repeated injuries? As these patients are polyuric, there is a risk of developing repeated episodes of hypovolemia and acute kidney injury. And this nephrocalcinosis can cause chronic tubulointerstitial inflammation, and they also have prolonged hypokalemia, which can result in a condition called hypokalemic nephropathy and resulting in chronic kidney disease. So, what are the steps that we can take to reduce the morbidity? To prevent the formation of calculi and nephrocalcinosis, adequate hydration has to be advised. Alkali supplementation in terms of citrate can prevent the formation of calcium stones. But remember, higher dose of calcium and higher urine pH targeting can also precipitate the calcium phosphate precipitation and result in increase in stone formation. Salt and protein restriction should be done so that hypercalciuria can be taken care of. Never restrict calcium intake, as Sarah has already mentioned that the acidotic state is the reason for the nephrocalcinosis and hypercalciuria. Once the calcium is acidosis is being taken care of, calcium will start remaining normal. Once if you restrict calcium, further calcium will be released from the bone and to increase the serum calcium, and that will result in a negative outcome. Now, one more point to highlight is that we should avoid thiazides, as this renal tubular acidosis is a condition which is associated with hypokalemia. We will be increasing the hypokalemia rather than preventing the hypercalciuria. Rickets and bony deformities can be managed accordingly. Corrective surgeries has to be done only after the growth plate fusion has happened. Overall, we have to avoid dehydration, maintain the potassium levels, and nutrition and growth has to be always taken care of. Are there any specific therapies to prevent the progression? Yes, in cystinosis, there is availability of cysteamine bitartrate, which is available as Cystagon, and they have proven to have efficacy in terms of improving the outcome. Similarly, there is Cysta drops available, which is useful for the cystine crystal deposition in the cornea. Are there any other specific targeted therapy? Yes, in tyrosinemia, there is availability of nitisinone, which prevents the cell injury by fumarate acetoacetate. This is a study where they have shown that there is an improvement in the tubular reabsorption of phosphate in children who have been treated with nitisinone. Similarly, there is a role of cornstarch diet if there is presence of fasting hypoglycemia in patients with glycogen storage disorder and Fanconi-Bickel syndrome. And recent evidence have been shown that empagliflozin, which is a SGLT2 inhibitor, have been shown to decrease the entry of glucose into the tubular cells and thereby decreasing the proximal dysfunction in patients with Fanconi-Bickel syndrome. But yet the further data is awaited. Nutrition and growth surely has to be taken care of. The maximum target of recommended dietary allowance has to be considered. Factors that usually affect the nutritional status in these children is the polyphagia, polyuria, which increase especially increased loss of micronutrients, and metabolic acidosis will affect the bone growth. And in children where the targeted calorie and protein intake cannot be targeted, gastrostomy feeds can be tried. This study showed a better improvement in the height and weight SDS scores with gastrostomy feeds. So, as per the guidelines which has been published from the European Society of Rare Kidney Diseases, the anthropometric parameters have to be monitored every 6 monthly, and dietary monitoring has to be done at least 3 monthly. The electrolyte monitoring as well as the urine calcium creatinine ratio has to be monitored 3 monthly once the child is being stabilized with the electrolyte and the supplements. And nephrocalcinosis and kidney stone evaluation has to be done annually.
And so clearly, just to summarize, we think that focused evaluation does allow distinction of proximal and distal RTA. The key forms are primary, but you can still remember that you could have acquired forms, and it's important to screen for underlying etiology, particularly in type 2 RTA, type 4 RTA, and so on. Genetics is very important, in evaluating these patients. It was not available before, but clearly with the availability now, I think we had a recent webinar of the IPNA, and the summary was, genetics, genetics, genetics. You need to figure out the cause, and as Srinivas very well said, that once you know the cause, some therapies are more focused than others, and so clearly, if you diagnose Fanconi Bickel and so on, you are able to manage these patients in a much more proactive manner. And obviously, supportive care is the key. A proportion of patients who have got RTA would progress to chronic kidney disease, and this is a concern which we do not encounter, in children. But once they transition to adult care, this is going to be a problem. So I think it's important to be seeing these patients on long term. So we will stop here, and happy to take any questions. Thank you.
Wonderful discussion, sir. I have 3 questions. The first is, if your case of SLC4A, that mutation, nephrocalcinosis was there, medullary nephrocalcinosis, and with the optimizing treatment, bicarb is now 20. In spite of that, the child is having stones. How to deal with that? Because he told that we have to avoid the thiazides in this condition. Urine calcium creatinine comes around 0.00 and all that. It is stabilized, but still the stones are there. How to deal with those conditions?
So if the stones are there and they are large enough stones, perhaps they are going to be amenable to therapy. But do remember, that once you get nephrocalcinosis, there's no way this nephrocalcinosis will go away. It is bound to stay. As you said, the calcium creatinine ratios have stabilized.
Okay.
So clearly there's no need for any active intervention. And he did mention about thiazides. So I think thiazides is a point, that we would all like to emphasize. You already have a channel disorder in the distal tubule. Why do you want to create another disorder? So by giving thiazides, you are creating a gentleman. So now you've got a RTA with gentleman, and much more hypokalemia. So we do not advise using thiazides at all. In fact, there are hardly any patients with RTA, distal RTA, who are given thiazides, at least in our hospitals.
If the stones are causing any obstruction like mild hydronephrosis,
Then they can be dealt with appropriately, so they would require whatever therapy is appropriate. So clearly you can either do a ESWL or you can remove them, get them removed. Yeah.
The second is, that's a very basic question. Can I know the content of citrate in the cital syrup? I couldn't get the content. Tried it off. It's a sodium hydrogen.
Sorry, which syrup?
Content of citrate milliequivalent in per 5 ml like that.
So
in the cital syrup.
based on the formulations, actually there are various formulations available. Most of the potassium citrate formulations available provide 1 ml 2 milliequivalents of potassium, and ideally citrate, as if you want to clear citrate dose, it's 3 milliequivalents of citrate, which gets converted to 2 milliequivalents of bicarbonate.
That they mention in the other syrup like Portrait SF and all that. But it is not mentioned in the cital syrup. They just
What is cital syrup?
That is disodium hydrogen citrate.
So
they just mentioned some milligram.
I think what he said, again, I'm sure one can calculate, and it's not difficult, we can email. But I would personally prefer not using sodium based formulations, because they would cause more hypercalciuria. In a proximal RTA, perhaps you can still use, but even in proximal RTA, there is also hypokalemia. So I would probably prefer using potassium based solutions. But I'm sure calculating this should not be difficult. You can probably take Srinivas's email, and write to him. He'll probably let you know. Yeah.
So this is regarding Srinivas' statement that deformity correction is to be done after fusion of epiphysis. How strong is that statement? And somebody is developing deformities at 8 years, 9 years, asking parents to get it corrected after 14, 15 years. So how much that statement is strong?
Not really, So suppose you really have deformities. We have often, as long as, the rickets is not active, the patient is metabolically okay, because if you do not correct, this is going to go on getting worse. So at times, we have gone ahead and got them operated even earlier. So this previous view, that you need to wait till bones fuse may not be that hard, So clearly, I think one is more flexible on this.
Nowadays, if you have corrected basic biochemical abnormality, you can think of deformity.
So, and this is true for all forms of rickets, even the hypophosphatemic variety. So if you've got, because as you grow older, the deformities are going to get worse, and correcting them later may be even more tougher. So just osteotomy and aligning them may do the trick, Yeah, Vijayalakshmi.
5.5 changed to 5.3. Sorry,
I know.
I missed that.
Most books would say 5.3. One can't be this kind of dogmatic about this over the precise value, but most textbooks would now say 5.3. But 5.5 is a good thing to remember by. For stones, they say that if you've got a pH above 5.8, evaluate for incomplete distal RTA. So I think anything that's around 5.5, above 5.5, one should start getting worried. But again, just to re-emphasize, use a pH meter and not just a pH paper.
I have one more question.
Yeah.
Um, I thought you clearly 2-3 times you have mentioned that there is no other etiology for both possibilities, distal and proximal. Somehow I used to think Wilson's, interstitial
You're right.
nephritis, these may be. So I guess
You're
I was
right.
wrong.
Wilson's can cause both proximal as well as distal. I don't know of any Wilson's that has really the combination. So Wilson's can cause distal RTA. Wilson's can cause proximal, and you're right. By just the copper toxicity per se, this can happen. And your interstitial nephritis, I'm not sure. I don't know. But perhaps the primary cause of a pure mixed RTA is carbonic anhydrous too. The others, could variably cause this. Yeah, you're right. Maybe, in fact, you could be right, about interstitial nephritis. I'm not really sure, But then do remember, and again, for the fellows, that when you have distal RTA, you may have proximal dysfunction. Don't label this as mixed, okay, because at times you are making this mistake.
Could that be due to PTH? I mean, we think that it is due to PTH.
You're right.
Is there-
Yeah, perhaps it's right, but perhaps the overall feeling, at least within nephrology, is that there's the acidic milieu in the proximal tubular cells that causes dysfunction. But I agree with you that PTH per se is a tubular toxin, and one of the reasons why you end up getting Fanconi in vitamin D dependence, is perhaps due to PTH. But the overall, because this gets corrected with time, and PTH normally does not rise too much, in RTA. The values of PTH, unless there is really a vitamin D deficiency or there is something else concomitantly happening, the PTH is relatively stable in RTA. So perhaps it's not PTH per se.
Sir, in presence of deranged renal function, how to establish that whether there is underlying RTA or not?
Tough to say, if I did not go into too much detail regarding type 4 RTA, but in type 4 RTA, one of the first steps was, that exclude. So if you really have a GFR above 30, then you can be quite sure that this is not causing the acidosis per se in a setting of CKD. If you've got a GFR below 30, it's going to be very, very troublesome, So 30 is the cutoff that's often used. Most of the dysfunction in acidosis really happens once the GFR falls below that, So that's a good value to keep by. Yes. Want to answer?
No, so we usually don't prefer using vitamin D3 as a only we use as a treatment, not as a supplement. So if you are able to maintain the levels of vitamin D3, that's sufficient, because this that can increase your hypercalciuria as well. If you are having a normal D3, then there is no need for supplementing a vitamin D. That slide I mentioned in the slide is if they have deficiency of vitamin D, then there is a need for supplementation. Sometimes there will be a question, is there a need to give vitamin D in a condition of hypercalciuria? But for maintaining the bone health, deficient state is not a good thing. So that's why vitamin D would be used as a therapeutic rather than a supplement.
So overall, we are not using vitamin D for managing patients with RTA on the medium term or long term. If required, one could give 400 units, but normally we are careful, and most kids do not. So the rickets does heal with just correction of acidosis. So we don't require as a routine, And why Fanconi Bickel in particular, did you ask? And Fanconi Bickel is being seen more and more, chiefly because you are doing much more genetics. And what Srinivas did mention was the role of SGLT2 inhibitors. There are more and more papers emerging that SGLT2 inhibitors are a good strategy, proactive strategy. Until now, the only thing that we had specific for Fanconi Bickel used to be uncooked cornstarch, which was so tough to take. But perhaps this may be something that can be done, prospectively in your patients, perhaps.
Thank you, sir.
Mhm.
Yeah, it was very good presentation. I just want to ask the safety data about the SGLT2 inhibitor while we are using, because they are more prone for the mycotic infections in the adult as well as.
SGLT2 is still evolving in children, and so we have not used SGLT2 too much for Fanconi-Bickel, but we have tried using SGLT2 inhibitors for our proteinuric patients. Uh, Again, the data is minimal. There are currently 2 trials happening at the institute, even worldwide. Infections का बहुत ज़्यादा risk नहीं है. The only problem that we have seen in patients with CKD has been the worsening of GFR. So transiently the GFR does decline, and theoretically it should come back. But we are more worried about the fall of creatinine, rise of creatinine in patients. There is weight loss is not significant, and we have not really seen too many mycotic infections per se. But I think this data is still evolving pediatrics may, but I definitely think it would have a role to play on the long term.
So as the time is short, we will be taking the last question from the ma'am. Yes, ma'am.
Sorry if
Yeah.
anybody else wants to. Okay. You mentioned the yield of genetics in distal RTA, but I missed whether you mentioned in proximal.
I showed you data from the institute, and Sukanya is sitting behind. She showed 95% in Fanconi. Now this could be a slightly overestimate, and it may be more like 80%, 85%. So Fanconi, you should be able to get a high yield, and particularly now with the whole exome sequencing. So clearly the yield is reasonably high. I think they showed a figure of Sukanya. I think 95%, Sukanya. 95% was her data on almost 100 odd patients with the proximal RTA, Fanconi syndrome. So the yield seems to be higher. But distal RTA, I think all over the world it's about 75%. And there are some unknown genes yet.
So thank you, sir. Thank you, sir, for the lucid lecture.
May I now invite Dr. Rajesh Khargawat and Ravinder sir, Dr. Ravinder, to felicitate Dr. Javinder. And sir, could you please have a photograph here?